Our last two abstracts, Dr. Sibylle Leubel from the German Breast Group is going to talk about the KATHERINE trial. This is a phase 3 clinical trial with adjuvant adatrastuzumab and tansine versus trastuzumab for residual invasive HER2-positive early-stage breast cancer after neoadjuvant chemotherapy and HER2-targeted therapy. These will be the final IDFS and updated OS analysis.
Thank you. Good morning, everybody. I first would like to thank the co-chairs of this meeting as well as the scientific committee to give us the opportunity to present the data today here at the San Antonio meeting. This will be the final IDFS and interim OS analysis of the KATHERINE trial. I'm presenting on behalf of my co-authors from NSABP GBG and the global investigators. These are my disclosures. So the KATHERINE study is a prospectively randomized phase 3 trial investigating whether TDM1 given for 14 cycles will improve IDFS compared to trastuzumab for 14 cycles in patients who had residual invasive disease after neoadjuvant chemotherapy and anti-HER2 treatment. Chemotherapy had to be at least 6 cycles, consisting of at least 9 weeks of taxane as well as 9 weeks of trastuzumab. Dual anti-HER2 therapy was also allowed, and the patients had to have invasive residual disease either in the breast and or the nodes. Radiation therapy as well as endocrine treatment was given at the discretion of the investigator and could be started concurrently with the anti-HER2 treatment. The primary endpoint was IDFS, and the interim analysis had been presented already 5 years ago at this meeting. The secondary endpoints were IDFS, including second primary cancers into the definition, as well as disease-free survival and overall survival, distant relapse-free interval, safety, and quality of life. Patients were stratified according to the clinical stage at presentation, inoperable versus operable, according to the anti-HER2 treatment, the hormone receptor status, as well as the nodal involvement at surgery. 1,486 patients were included in this trial. This is the final IDFS analysis, which demonstrated a significant and clinically meaningful reduction in risk of the disease of 46%. With TDM1 over trastuzumab. And you can see the 3-year data were 88.4% versus 77.1%. We are now at 80.9% versus 67.1%. This is a 13.7% absolute difference and a hazard ratio of 0.54. This was highly statistically significant, and for information we also included the 5-year data for TDM1 as well as trastuzumab into this slide. This final IDFS analysis triggered the second interim overall survival analysis of the KATHERINE trial, and here you can see clinically meaningful reduction of 34% in the risk of death with TDM1 at the second interim analysis. You can see here the 7 years overall survival data, 89.1% compared to 84.4% with trastuzumab. This is statistically significant and with a hazard rate of 0.66, and the absolute difference between the two groups of dying of breast cancer is 4.7%. So let's look at the subgroups. The data were very consistent across the pre-specified subgroups. In gray are highlighted the stratification factors. On top you see the overall results with a hazard ratio of 0.66. Of interest is always, do the hormone receptor positive patients have the same benefit from a new treatment as the hormone receptor negative? And here you can see there is also even a slight trend that the hormone receptor positive patients may even derive a larger benefit at this long-term treatment with a hazard ratio of 0.6. The last group is the nodal involvement. At surgery, patients with node positive derive a larger benefit than patients with node negative disease as expected, and all other subgroups are as expected. We also looked at the safety beyond the treatment cessation, and only a small number of patients observed an adverse event in the post-treatment period. You can see here cardiac disorders were of special interest, and you see 5 patients in the trastuzumab arm had a cardiac disorder compared to 9 patients. Can I read that? Compared to 5 patients. It's difficult. 5 patients in the TDM1 arm. Serious events were even lower, only 3 patients in the trastuzumab arm and nil in the TDM1 arm. And grade 3 and beyond cardiac safety events were 3 and 1 in the TDM1 arm, just to demonstrate that the long-term toxicity is really very low, which is important. So in conclusion, for KATHERINE, TDM1 is the first targeted agent to provide a significant survival benefit in patients with a high risk of recurrence after having received already a neoadjuvant treatment, having invasive residual disease following those treatment. After a median follow-up of more than 8 years, we have seen here a statistically significant as well as clinically meaningful reduction in risk of death by 34% with TDM1 in this setting compared to trastuzumab, which is really very important for our patients. This benefit was seen irrespective of the extent of the disease at presentation, the hormone receptor status, which is very important, and the presence of absence of lymph node involvement at the time of surgery. This is consistent with the primary analysis final data for IDFS, which we demonstrated 5 years ago, and the benefit continues to be consistent with a longer follow-up, and the risk reduction of a recurrence is 46%, with an absolute benefit of 13.7% at 7 years with TDM1. The safety profile remains consistent with the previous analysis, and there were no new safety signals identified at this time. So I would like to thank all the patients who were brave enough to participate in the KATHERINE trial, and along with their families. I know patients were very disappointed at that time when they were randomized to the trastuzumab arm, so a special thanks to the patients who really stayed on the standard arm. And I also would like to thank the KATHERINE investigators and their research team around the globe in 273 sites in 28 countries. Thank you.
Thank you, Dr. Leubel.